what I show you very quickly, meaning the weighted sum can be done using different statistical models. Basically, to make things easier, you have two different approaches. The first one is called the fixed approach, and the second one is the random, the fixed effect model, and the second one is the random model. And this is one of the ways that you have, from the statistical point of view, to try to deal with heterogeneity. So usually, when the results of the studies are enough similar, you can go with a fixed effect model that it's more precise by definition, because, the assumption here is that all the studies belong to the same population. So the estimate you have is more precise. When there is heterogeneity, usually you should use random effects model. And in that case, what the statistical approach does is to take into consideration some of this heterogeneity, so the confidence interval of the estimate of the meta-analysis is wider. So the point estimate will not change, but the confidence, so the length of the interval, the confidence interval will change going from one model to another. And this is one of the ways you have to include heterogeneity in your estimation. And be careful, because the precision of the estimate, it depends on the number of patients, but also, and more directly, on the number of events, meaning the patients that have the outcome in the study. So you could have, it's not common, but you could have studies with a smaller sample size, but a higher frequency of the outcome that weights more than bigger studies. Usually it's not the case, but if you have population where the outcome of interest is more frequent, for example, subjects with a higher severity of the disease, you could assume that in that population the outcome, the bad outcome, comes more frequently. So a smaller study can weight more than bigger, because it's the number of events that drives the precision of the estimate, not just the number of patients included in them. Okay. So we'll learn about the systematic reviews and meta-analysis. We forget for a moment the narrative reviews, because we discuss about the fact that they are not the best type of information we want to use for clinical decision making. And here we try to go from systematic reviews to tertiary literature sources. And I would like to discuss with you 3 examples. We could provide more examples here, but I think these 3 categories of documents represents more or less the major tertiary literature you could see in your work and your research. The first one is what we call point of care summaries, or in general information summaries. These are a kind of further digested source of information, putting together different systematic reviews, different clinical guidelines, different type of information organized to illustrate and support decision making very close to the patient care. Usually, you have to imagine that some years ago you were probably at the primary school, but doctors used to use books to study and to focus on a given patient. Of course, books are now less used or less common, because as discussed before, the information is rapidly increasing, new studies are coming out almost every day. So you need something that is more dynamic, that allows you to take decision, taking into consideration all the available evidence and all the updated evidence. So this type of information summaries are just, you can imagine that it's a book, a kind of book about a given disease or a given condition, but it's constantly updated, and the information there is filtered to be as much as possible relevant for clinical decision making. So for instance, the chapters of this book are organized around clinical scenarios, because usually doctors have this kind of mental structure. They have a patient in front of them, and they try to bring up solutions for that patient or similar patients. Okay, so again, a pyramid, because these point of care summaries, these information summaries, are based on good clinical research, so good clinical trials, good primary studies, good systematic reviews, and they collect together all these different sources of information. One example, maybe here in Varese, I don't know if you have some of these solution. These are commercial solution. Editors, almost all the editors that publish medical journals have developed their own point of care summary. So EBSCO, Elsevier, Walkers, and so on. This is just an example. I don't have any money from Dynamed. It's just because it's one of the simplest example I can bring to you. So you search as in Google with a very simple engine, search engine, and what the system gives you is a selection of chapter books where you can find not only if A and B, which is the best treatment between A and B as in systematic reviews, but you could have an overview of the disease, so a kind of narrative review. You can have details on the efficacy of the different treatments. Again, here I brought to you the example of vitamin D in elderly people. So if there is the need for supplementing vitamin D in an elderly person, what are the consequences of vitamin D deficiencies, and so on. So you see, we are making the question broader and the answer broader, but keeping in mind that these contents are built on systematic reviews as much as possible, where there are systematic reviews, of course. We did some years ago a kind of evaluation of these tools, because to be sure that they are all promoted as evidence-based. But of course, this may be true or not. And what you should consider, again, this is a complex type of information source, but if you want to understand if the information source is valid, relevant, and transparent, you should assess the editorial policy, how the different type of information sources are put together, by whom, under which type of protocol, process, how they use evidence-based information rather than opinions, rather than case studies, and so on. And of course, you need to consider how they are constantly updated, because otherwise you are using an information that it's not the newest one. And when I said newest one, don't think about what is the last study saying about that, but it's taking the last studies and read it and embed it into the knowledge, the previous knowledge. So, for example, taking the last study, RCT, into a meta-analysis or into a systematic reviews of the available evidence, okay? Another step forward in that sense is taking this information base and linking to patients' data. Don't know in Varese, ma no. in several hospitals or in several primary care systems, data for the data of single patients are collected into health record, electronic health record. So you have a structured form for each patient. You collect the data, and these systems are engineered to put together the information of a patient with the information of the knowledge base. And the output, it's a kind of second opinion. What should I do with that patient? Did I change the treatment because of an interaction, for instance? So these systems that are called clinical decision support systems are just a way to take the information from good quality information source and link it to the patient. The final objective of all these systems is simply to have an information that is tailored, that is specific for a given patient. This is not future. In many countries, these type of clinical decision support systems are already in place. We did some research on that type of systems, and we did a trial to understand if a system like that can help in taking good decisions, so in improving the care of patients. Of course, this not means that the doctors will be substitute with computers. The doctor uses the information that the system gives him and put it in his own medical reasoning, of course. This is a kind of assistance into the medical practice. But again, you should be aware that all the systems, apart from the technology, should be based on high quality evidence. Otherwise, we are telling something that it's not evidence-based, okay? Going to something that is probably more familiar, let's talk about clinical guidelines. You probably all know about clinical guidelines, so a set of recommendations intended to help health professionals, especially doctors, in taking informed decisions. This is the definition from the WHO. Usually, clinical guidelines also define what is the best practice, okay? What is written in the clinical guidelines usually is what a doctor should follow to apply best practice, bad medical practice. In some countries, such as Italy, clinical guidelines have also let's say a scope that it's oversee medical practice. They can be used to define if a doctor is liable or not if something happened to a patient. So, especially in Italy, but also in other countries, clinical guidelines are increasingly their importance and their power because of this type of use that governments and hospitals are doing with clinical guidelines. Usually, clinical guidelines are produced by scientific societies. This is more or less the process. Well, in the past, they bring together around the table the experts in the field, and they wrote the clinical guidelines. So, what to do with a patient in that conditions, which drug choose as a first-line treatment, which type of diagnostic procedure or diagnostic pathway follow for make a diagnosis or staging a given disease, and so on. Nowadays, luckily, we have more structured way to produce clinical guidelines, because if you make a comparison between narrative review and systematic reviews, clinical guidelines constructed by people around the table is a kind of narrative process, right? Anyone brings the literature that has read before. There is no a formal way to pick up one study or another. So it's like a kind of writing a narrative review altogether, but with the scope to provide recommendations. While the systems that are now in place to produce clinical guidelines have the idea to structure the process and to provide more evidence-based clinical recommendations. In general, a good clinical guideline should be multidisciplinary. As you can see, we are increasing the complexity of the document we are talking, right? So if you are writing the clinical guidelines for treating early breast cancer, you should have at the table or in the process of developing the clinical guidelines, not only the oncologists, you must have the surgeons that makes the mastectomy, for instance. You should have the radiologists because part of the treatment is based on radiotherapy. You should have the pharmacologists because there are several new drugs coming out, maybe, and you might not have a clinical experience with these new drugs. We might have the need to include patients into the process to be sure that what you are recommending is something that is really relevant for the patients. So while a systematic reviews is done by a small group of people, maybe you have, it's always good to have different expertise in a team, but in the case of clinical guidelines, this is almost mandatory, okay? It's quite impossible to produce a good clinical guidelines without having all the parties involved in the process, all those who are affected by the clinical guidelines, okay? This brings a lot of problem in the discussion because, of course, the majority of the people very much involved in a field are also those who are much conflicted, more conflicted. So you have to have in place some systems to at least disclose the potential commercial or intellectual conflict of interest, or you can decide not to have the experts in the panel preparing the clinical guidelines. This is not always, not very, very, very common, but you could also think about guidelines done by people who are not experts in the field. Clinical guidelines have their own methods to be developed. And again, it's a matter of robustness and validity of the methods that are applied. The more the methods applied are robust, the more the results of the process is valid. So when you read clinical guidelines, there should be somehow described how the evidence that are in the clinical guidelines were collected, appraised, and presented. And inevitably, any clinical recommendation is a trade-off between benefit and harms. There's nothing that we can say is only producing benefit. So at the end, the recommendation is always a balance between doing the good things without not doing many bad things, okay? And the last point is that we cannot say that all the recommendations we have in a clinical guidelines have the same importance, the same strength, because in some cases we don't have the evidence to be sure that something works. So we can recommend something, but we need to be explicit on how is the strength of that recommendation. If you have an infection, you should take the antibiotics, no doubt on that. But in other areas, and with the complexity of medicine nowadays, the majority of the areas are that way, you simply don't have enough evidence, or the evidence is not enough robust to say that something really works or something really doesn't work, okay? So we will see the grade approach and how in the grade approach this concept of making explicit the strength of recommendation is elaborated. You don't have to forget that recommendations are judgments. You could base this judgment on the evidence, but at the end, it's still a judgment. Okay? So you need to be transparent on how you reach to that judgment. So you allow the readers, the doctor that is applying the clinical recommendation, for instance, to understand the process and to understand if that process meets the situation he's working with. This is because the research evidence, the evidence, so the results of the systematic reviews of primary studies and so on, is just one part of the decision-making process. This should be something that you always have in mind when you talk about decision. Evidence is one of the important block of the decision, but it's not the only one. Because you could have evidence saying something that it's unfeasible, because we are in Uganda, we don't have money to pay for very costly drugs, or because a patient doesn't want that kind of treatment. Patient doesn't want to do surgery, for instance. So you could have a good evidence telling you to do something, but that recommendation cannot be implemented for several reasons. So the step you have to take from systematic reviews to clinical guidelines is this one. Systematic reviews are a summary of research evidence, and usually they do not recommend something. They just allows you to have a summary of the evidence. And then you take the summary of the evidence and you put it in your context. That's why clinical guidelines are usually conducted in a given context, not apart from the WHO clinical guidelines that are more or less applicable, at least in principle, to any country in the world. Usually clinical guidelines are local or national or are in a given setting because values and circumstances change from one situation, from one environment to another, okay? While in theory, research evidence should be the same all over the world. This is not completely true, but we can think that clinical evidence are something stable, that it's just putting new data and revising the data we have. And what changes in a clinical guidelines process is circumstances, values and preferences of patients, of doctors or systems or governments and so on. Okay? This is more or less a diagram that summarizes all the different steps of the development of a clinical guideline. Of course, this is just to give you the flavor of the complexity of the process, okay? You should start putting together those stakeholders involved in the process, so you should gather information from them, and then you should create a panel that will produce the clinical guideline. In the panel, you should have, as mentioned before, the different professional figures involved in the process. And then usually you have a group that it's more devoted to the methods of the clinical guidelines, so meaning putting together the literature, appraising the studies, provide to the panel a synthesis of all this literature, then ask to the panel to make the recommendation. And a very important thing to do at the very beginning is to formalize what is the scope of the clinical guidelines. It's really different to produce a guidelines to be used in a hospital in Lombardy or to produce a guidelines that is applicable to all the European citizens, for instance. So the scope is totally different. The questions may be different. The target is surely different. So the first thing to do is really to start with the context. It's also different if the Italian Society of Laparoscopy, I don't know, or the European Society of Laparoscopy decide to start with a clinical guideline, right? So the first thing is, which is my context, and the context of my guidelines. And then you have to frame the question of the guidelines, because ideally the clinical guidelines will end with a set of recommendations. Do that in that patient, don't do that in that patient, or do that in that situation. And each of the recommendations should be linked to a clinical question to be used really by those who have to use the clinical guidelines. Then there's a phase linked to the summarizing of evidence, something we all may understand now. And then there's a step that goes from evidence to decision. Again, there's the issue of updating clinical guidelines, because as systematic reviews, clinical guidelines in some areas go rapidly out of date. And this is the first paper that has been published 10 years ago about the grade approach, that it's one of the most popular way to produce clinical guidelines today. That's why I talk a little bit about the grade. There are several other systems to produce clinical guidelines. This is just one of the really most popular. It's adopted by a lot of national and international society and bodies doing clinical guidelines, and also the Italian national guidelines system that has been launched again a couple of years ago, adopted the grade methodology to produce clinical guidelines. So if you will be involved in some way in producing clinical guidelines in Italy, we will probably come up with a great clinical guideline. Basically, the grade was proposed to try to overcome the limitation of having several different ways to produce clinical guidance, but also to grade the level of evidence, the strength of a recommendation. I don't know, in several documents you would have 1, 2, 3, 4, with 1 a good recommendation, 2 average recommendation. In other systems you have A, B, C, 1A, 2B. So it's really difficult to compare the recommendation from one clinical guideline to another, and the system was really complex and heterogeneous. So the grade was primarily developed to harmonize the system and to make some of the steps of the clinical guidelines development transparent and accountable. This is the website of the grade. If you are interested, I suggest you to have a look. It's full of information about how to produce a good clinical guidelines, and full of tools and practical tools, including one software that assists all the parts of the clinical guidelines development. Just to introduce some basic element of the grade approach, the first element that it's really a kind of revolution in guidelines development that grade introduced is the predefinition of the outcomes that the clinical guidelines will use as critical to make recommendations. So imagine that you have, again, early breast cancer guidelines. You need to pre-specify before starting looking at even at the literature, which are the outcomes on which the recommendation will be mostly based, which are the elements in your decision making that are more important than the others. If you think that a treatment for early breast cancer should make women live longer, your outcome, your critical outcome, is overall survival. If you think that a treatment for early breast cancer should make women live better, then you could introduce quality of life. If you are a radiologist and you think that the critical outcome for your decision making is the results of an MRI, you will take that outcome as critical. Depending on the different perspective in the system, you might have different judgment on what is critical. But at the end, the panel that is composed by those different people will come up with a proposal of what is critical for the decision making. And after that decision, you see for the grade approach, you have critical outcomes. So for following that outcomes, you will issue your recommendation. The other outcomes are not forget, but they are less important when reaching a conclusion, okay? So you collect the data also for the important and other low importance outcome, but at the end, the panel should decide on the basis of the critical outcome. And this is something that it's not really, that was new with the grade approach. Usually, the other systems of guidelines preparation did not specify at the very beginning the critical outcomes. The second issue and the second great idea that the grade approach bring into the discussion is really to separate the quality of the evidence with the strength of the recommendation. A clinical guidelines, again, it's something that derives from a complex process where evidence are a very important part, but not the only one. So you could reach a strong recommendation in some cases, not always, of course, also if you don't have very strong evidence. Usually, strong evidence means strong recommendation, but it's not always the case. Yeah. Exactly, exactly. Yes, what grade does is to assign a level at the quality of evidence, and the levels are 4. So you could have high quality, moderate quality, low or very low quality of evidence, and then in a separate, let's say, process, assign an indicator of the strength of the recommendation. That can be weak or strong. So usually, yes, to finalize the process, so to provide a recommendation, you should take into consideration the quality of evidence and the other things you have mentioned before. And we will see how the grade try to put together all these aspects in a very schematic way to allow the member of the panel to consider everything and to come up with a recommendation. It's of course a complex process, but the methodology also for clinical guidelines development has improved a lot in the last years. Something that was done in a totally informal way with people thinking about all the stuffs is now done with a more structured approach because of transparency, because of several things. Okay, of course, you could have, recommendation in one way or another. You can recommend to do something, or you can recommend against doing something. This is not something we are used to think about, but if you think about this investment of treatment or diagnostic exam that don't work or they are not useful to identify patients, you could think also about having a recommendation not to do something, okay? And again, the recommendation against something can be weak if you don't have a lot of information or if your idea are not completely one way, or a strong recommendation against something. This is the summary of findings table that you could find into some systematic reviews, such as the Cochrane reviews, and in some clinical guidelines, because this is really the bridge between systematic reviews and clinical guidelines. And it's the table that summarizes you the quality of evidence and the magnitude of the effect. Because, of course, in your clinical development guidelines process, you must be aware about the quality of the evidence, but also about how large is the effect. How many lives I would save if I do a given intervention, right? So this table, that it's quite complicated, but at the end, maybe it's not, I don't know. The first thing you have to understand, again, at the very top you have the title. So we are talking about women, postmenopausal, and older people who risk fractures because of osteoporosis. We are in a setting that is a community or institutional setting. Something we didn't discuss about this in the systematic reviews, but as I was telling you, the setting is really relevant for the clinical guidelines, because it's different to treat a woman that is outside the community, for instance, or it's not in a hospital, rather than treating a person that is institutionalized, okay? The intervention we are testing here is vitamin D, again, plus calcium, and the control is placebo or another kind of control. Without going into the detail, otherwise we will stay here until midnight, what you have to bring from this picture is that we make a reasoning around an outcome. The GRADE approach forces you to reason about the benefit, and a benefit is an outcome, okay? In this case, the outcome is hip fracture. These are the effect of the intervention, and the way to summarize the effect of the intervention is in absolute measures. Not relative risk, not odds ratio, not other ratio, but how many people will have that outcome if I treat them or if I don't treat them. This is something that even the less smart doctor, even the less smart person can understand. It's not because of mathematics or statistics. This is common sense. If I don't use vitamin D, 8% out of 1,000 will have a hip fracture. This is the baseline risk of the population, of that kind of population. If I use vitamin D plus calcium, 7% will have a hip fracture out of 1,000 treated. This is really clear. Is it a big difference? Is it a small difference? If I don't do anything, 8. If I do something, that it's taking a vitamin D, it's not a big intervention, I would say, but it's taking a pill. My mom already takes something like 13 pills. So, this is a way, just a parenthesis, this is a way going from risk ratio 0.84. This data comes from here. We are not coming from the moon. It's just an elaboration of the risk ratio in absolute terms. This allows you to make a reasoning on real data, on real person. If I see 1,000 women in my ambulatory in 6 months, I don't know, maybe 1 year, 8 will have hip fracture, even if, okay, I do something good or bad. If I prescribe them vitamin D and calcium, 7 will have it. This is a way from going from, and it's a way to present the results of, this is a meta-analysis. You can see it here. We have 9 trials. These 9 trials included almost 50,000 participants. The point estimate, the meta-analysis, is 0.84 with the confidence intervals that goes from 0.74 to 0.96. So the result is statistically significant, right? Because it doesn't touch the null effect. The relative effect is quite huge. I can say you that this is a 16% risk reduction in hip fractures. If I tell you that intervention is allows you to have a 16% of risk reduction, would you be more impressed than if I say that one hip fractures is safe, right? Because this is not a false. It's just because relative measure tends to increase the differences. And this is the quality of evidence, the grade quality of evidence. This means that this estimate comes from high quality studies. Here we have the quality, the risk of bias, but not only the risk of bias. Here we have, for example, heterogeneity, the differences between the studies. We have the precision of the estimate. We have the risk of reporting bias. So we have a lot of different problems that could affect the quality of evidence. So with all this data, you, sitting in a panel of a clinical guidelines, can make a decision about the quality, about a part, one of the parts of the clinical decision-making process, the one linked to the evidence. But we said that the system is more complex. We do have to take into consideration other aspects, values, preferences, setting, economical resources, and so on. So the grade proposed a framework to go from evidence, so the summary of evidence you have seen before, to decision. This, again, very complex. I don't have the time to go into the details, but I don't know if you could see it here. We have how important is the problem. Of course, it really depends on, are we talking about plastic surgery for soubrette, or are we talking about saving women with early breast cancer? So the magnitude of the problem, the benefit and harms of the options, so coming from the benefit and harms of the summary findings table, the use of resource, the equity, acceptability, feasibility, all these aspects are summarized in this framework that it's used by the panel to take to develop the recommendations. This is an example of a clinical guidelines done by this Endocrine Society of Clinical Practice, and it's about evaluation, treatment, and prevention of vitamin D deficiency. It's published in a medical journal, so of course this is a very short summary of a long document. You could have access to the full clinical guideline, that it's a 80 pages document. Of course, this is a short summary. But even in the short summary, you should have a part dedicated to the methods. Here, they just say you that they apply the grade approach. But then there's an appendix where you can have all the information about the methodology. And this is the way, one way, there's no one single way to provide the recommendation. So we recommend prescribing vitamin D supplementation for fall prevention. We do not recommend prescribing vitamin D supplementation beyond recommended daily needs for the purpose of preventing cardiovascular disease and death. And here, there's the grading of the evidence attached to that recommendation. Okay, questions about clinical guidelines? This was really a Miami of the clinical guidelines development, but just to give you the idea that it's a complex world. So if you ask me, should I read the clinical guidelines or a systematic reviews? I would say, let's start with the systematic reviews because it's easier to interpret it and to appraise, while clinical guidelines is more complex. But of course, if you are a doctor practicing in the hospital, you might have the need to go and read and appraise clinical guidelines. Okay, very similar to clinical guidelines, but taking the perspective of policymakers or people deciding to put a drug in a formulary or to buy a new machine for the hospital. We have health technology assessment reports that are systematic evaluation of properties, effects, benefit and harms of health technologies. So not only drugs, but also, for example, medical devices or basically medical devices or organizational changes, stuff like that. It's, again, a multidisciplinary process because it's not only about evidence, but it's even more about resources should have the money to pay for that technology. This is an easy question, but who has to decide to implement or to promote one technology should have the money to cover for the cost, not only the cost to buy the machine, but the cost and the personnel to run the machine, to have the reagents and so on. So it's really a complex process that takes into consideration evidence, but also social, economic, organizational, and ethical issues about the introduction of a health technology. And the purpose is just to, of course, to decide if one technology should be implemented or not. There are less standardized methods to produce health technology reports. There are not a lot of standard formats. There's a European harmonization effort that it's called UNETA that is trying to put together different systems in the different European countries on how to do health technology assessment and produce health technology reports. But we still don't have a single standard methodology for doing that. This is an health technology assessment by a Canadian agency about vitamin D testing in general population. So here we the report focuses on, do I have to test people for vitamin D deficiency before starting the treatment? That's a technology in a very broad sense. It's a population intervention. And usually the health technology report has a conclusion and implication for decision section, where briefly the evidence are summarized and the recommendations are proposed to policymakers. Something similar to what happens to in clinical guidelines. What is really important is that usually health technology reports have the cost effectiveness part, because cost and use of resources is one of the main driver of decision in that context. Okay. So just to summarize and go to the last part, this was one question from Alessandro, and to be honest, I don't know how to tell you, because which should we choose and why among the different types of documents I've shown you before. Of course, it really depends on what you have to do with that document. If you want to learn something new in a field, start with a narrative review. If you want to have a robust summary of research in a given field, take a systematic review. If you are a clinician, maybe a clinical guidelines is more relevant for you. If you are at the drug agency, you might need a health technology report. But be aware that the greater is the information source complexity, the more difficult it is to appraise, of course. You need to take into consideration several aspects. There are some tools for systematic reviews. Amstar and Robinsize are tools to assess if they are properly conducted or not. For the guidelines, you have the AGREE checklist that it's useful and can be used to, even if you are reading a clinical guideline as a reading tool. So very briefly, where do all these documents are? Of course, they are in the web. So you can look for these documents using Google, and we all do that. There's nothing bad in that. But of course, Google gives you everything, not only narrative reviews, which is at the very bottom, but also opinions by people, crazy people. So we are more evoluted, and we usually use literature databases. The literature databases, you all know it's Medline. I think you all have done at least one search in your life using Medline. It's very simple, of course, if you use it as Google, but if you are doing something more complicated, it's really a complex database. There are a lot of features that you may apply by searching with Medlines that really creates a new job. The librarian doing systematic research of the literature is really a job profession. It's something that is doing that every day with a high level of expertise. This is just a stupid example, vitamin D and elderly. Here you have some suggestions from the system, which are usually good, but don't stop here because your relevant paper may be at page 2, 3, or 4. Very easy is to put filters and limit. Here, for example, you have the limits for clinical trial. If you are interested in clinical studies about vitamin D and elderly, just click here and the system will filter for clinical trials. This doesn't mean that that it's not a clinical trial is out, unfortunately, because the system is imperfect. There are people that put tags in each of the articles, so it's a human activity and is prone to error. But of course, you can see here the records were more than 22,000, and with the limits are 3,500. Still a lot of records to be checked, but of course a more manageable number. This is, I don't know if we don't have a lot of time, but this is the dictionary that stands behind Medline, that it's called MESH. It's just a way to be sure that you are not losing articles just because they call the same concept in a different way. PubMed is a global database. So even with a simple concept as vitamin D, some articles could be recorded with the name of the two main molecules belonging to the definition of vitamin D. So if you use the MESH dictionary, by clicking vitamin D, you are sure that you collect all the articles that mention the single molecules. Okay, it's just a way to be more sensitive in your search. Vado avanti. Maybe these are concepts that you already have. Are you familiar with the PICO framework? Did you talk about PICO and Boolean operators? This is just a very stupid example. Let's imagine we are interested in collecting the studies that talks about using helmets while going by bicycle to prevent head and facial injuries. This is not a medical issue. Well, it is also a medical issue, but maybe, for example, a policy issue if I want to introduce the law to put the helmets as mandatory for people going by bicycle. Okay? So you can play the role of policymakers or doctors that is in the PS. So, which is the population? PICO stands for Population, Intervention, Control, and Outcome, which is the population of our question. Cyclist. Cyclist is the population, right? Which is the intervention? Helmet, right? Which is the control? No helmet. Which is the outcome? Head and facial injuries. Okay, so if I have to look in the literature to find studies, for example, RCTs, because I love randomized control trials. How is framed your search in PubMed or in Google, or whatever you want? What do you write in the engine search string? You are not an expert in a literature search, so let's just put some words. Okay, so which words you will put? Cyclist, right? No, the question is very simple. It's not a different. We are almost at lunchtime, so no difficult questions. So cyclists and helmets. How do you combine these two terms? Are you interested in all the literature about cyclists and all the literature about helmets? No. You are interested in the literature that talks about cyclists and helmets. So the Boolean operator you will use is an AND. That is the Boolean, the link that allows you to gather the information about studies talking about cyclists and helmets, right? Since we are interested in collecting only RCTs, we put in AND also RCTs. There are filters in the major medical literature to allow you to search only for a given study design, especially RCTs. Okay, so you put cyclists, helmets, RCTs, all in AND, and the system should gives you only the RCTs talking about cyclists wearing or not wearing helmets. You could have more specific search, for example, by introducing information about outcomes. But my suggestion would be to start broadly and then refine the search strategy step by step. The other very often used Boolean operators is OR, and this is meant to expand the research. Okay, Medline is not the only medical database. For sure, a very important one is Embase. That has the drawback that it's you need a subscription. You need to pay to enter into this database, while Medline is free for everyone. Embase has different journals, as the same journals as Medline, but more journals, especially in biology and basic sciences. So it's relevant, especially if you are looking for information in that field of research. Then you have other databases more specific for a given health professional. For example, this is Sinal. It's behind Eric, but it's called Sinal, and it's very useful for nurses. And Eric, that it's very useful if you are interested in papers talking about educational sciences and training of health professionals. These are just examples. There are tons of other medical. Of course, if you are doing a search strategy for a systematic review, the things are more complicated than just put helmets, cyclists in AND in PubMed, and that's it. There are a lot of rules and robust methods, but we are not going to talk about this now. One single thing is usually for systematic reviews, you search different databases, not just one. And as we were talking at the very beginning, we search also other sources, not only medical literature, but unpublished, for example, or ongoing studies. This is the database of the gray literature, so thesis, abstract, and other type of research that may be published, but not in standard medical journals. And this is a trial registry, probably the most famous trial registry, that is clinicaltrials.gov. You might have heard about it, because clinical trials are more and more registered at the very beginning of their conduction. This is because of the problem we were discussing before, that clinical trials are conducted but not published. So this is a way to reduce or to try to control the issue of reporting bias. So if you are especially working in a field where there is the risk of reporting biases, or if you are interested in a very new type of evidence, for example, ongoing studies or studies that are still not published because they have been concluded in the last weeks or month, you should have a look to clinicaltrials.gov. It's a US-based registry, but it hosts clinical trials from all over the world. We do have an European registry, but it's not so so important as this one. And this is, well, I'm in the drug policy laboratory, so I'm particularly interested in regulatory documents. A lot of studies are not published, but we are talking about drugs here. They are not published, but they are included in the regulatory documentation that is filed to regulatory authorities in order to get a marketing authorization. So these documents, which are since few years available because they were considered completely confidential before, can be obtained by, in Europe, for example, the European Medicine Agency website. Okay. Of course, they are not publicly available to everyone. You have to register, you have to get the approval to get the documents, but things are moving in that sense. Where to find the secondary and tertiary literature? Of course, each of the major databases we have seen contains systematic reviews, clinical guidelines, and so on. So you can use the filters that these databases have to find, for example, systematic reviews. This is very important. It's the register of systematic reviews, because as clinical trials should be registered upfront before starting enrolling patients, it's a good idea to register also systematic reviews before starting collecting data. This is because systematic reviews are research projects, so you have to plan in advance your methods to be more accountable, okay? So it's called Prospero, and it contains the prospective registration of systematic reviews. Then you have other type of database like the TRIP database, also evidence search, that have filters to find systematic reviews, very useful. And of course, the Cochrane Library. The Cochrane Library is the publication of the work of the Cochrane collaboration. That is one of the most important global organization producing systematic reviews. So if you are looking for systematic reviews, my suggestion, here I'm a bit biased to be honest, go to the Cochrane Library and check if there is a good Cochrane review on that issue. The Cochrane Library not only includes Cochrane reviews, but also other type of reviews, systematic reviews. So it's a useful source of information if you are looking for systematic reviews. This is the Cochrane Library website, and here we have the vitamin D systematic reviews produced by the Cochrane. Okay, that's it.